talk, which is, not repeating, but similar to Dr. Sanjeev Patnaik's talk. So first of all, I'd like to thank Dr. Arun Singh sir and Ashish Singh sir for inviting me here today. So speaking about management of bone defects in TKR, just for the delegates, I'm going to go quite simple. So first of all, you need to know that bone loss in TKR can happen both in the primary and the revision scenarios, but it's most commonly seen in revisions. So what's the etiology? In primary TKR, it can be one of many things. It could be a sequelae of fracture of the tibia, bone cysts, previous osteotomies, inflammatory arthropathies, and tumors as well. Usually, the mechanism in varus defect usually contributes to peripheral collapse on the medial tibial plateau, most in the posteromedial side, like you can see in this diagram over here. Bone loss is usually more marked posteriorly when there is an associated flexion deformity. But when you look at a valgus knee, usually you have bone defect in the tibia, but this is more of a contained central defect, if you can see in this diagram over here. And also there is a lateral femoral condyle defect as well, usually associated with it. So what about causes of bone loss in the revision scenario? So one of three things: stress shielding, wear debris, and implant loosening. One of these three things can be the reasons for bone loss in a revision scenario. But the mechanism again is different. So if it's stress shielding, it causes an osteopenic type of bone loss behind the prosthesis and is due to pressure shielding by the implant. But if it's wear debris causing the bone loss, it's more of a osteolytic type of bone loss, more seen in young males overweight who've already had a TKR. Implant loosening can either be aseptic or septic. And of course, iatrogenic damage can also lead to bone loss. There are many classifications. Let's not go into too much of depth. But the ones we usually use are Rand's classification, the AORI classification, and the Eng's classification, and the Clatworthy and Gross classification. So the Gross classification basically classifies it into contained or uncontained, or a combination of the two. Contained defects have an intact cortical rim, like we saw in the previous picture, while uncontained defects involve a segmental bone loss without any remaining cortex. The treatment for bone loss depends largely on these two factors, whether it's contained or not, and the size of the defect as well. If you say all the main classifications side by side, Rand classification is the simplest one. You see how much of deformity is there, how much of defect is there, less than 5 mm, 5 to 2 mm, and more than 10 mm. Gross classification is contained or uncontained, and the AORI classification is FT depending on whether femur and tibia, and then again 1, 2, 3 depending on the amount of the defect over there. So I'm not going to go into too much details over here. So type 1, if you can see, the cortical rim is intact. This is important. The cortical rim is intact, so it's a contained defect. And F1, T1, depending on if it's a femur or the tibia. Small amounts of bone loss, not compromising the component stability. So it's a contained minor defects. Type 2, the cortical rim is partially lost, and there's a defect in the metaphyseal bone as well, as you can see here. And this may again you have 2A and 2B. Depending on whether, if it's a unicondylar, it's 2A. If it's bicondylar defect, you have 2B. Type 3, you have cortical and metaphyseal bone loss, and there's no reference point for the joint line anymore because there's significant bone loss compromising the major portion of the condyles along with ligamentous instability. And of course, this is an uncontained defect. So how do you manage? First of all, you want to get your ESR and CRP to make sure it's not an infected case. Imaging studies, of course, X-rays, weight-bearing X-rays. Sometimes the CT scan may also be helpful. So when you manage surgical options for bony defects in primary TKR, first is you can resect near or to the bottom of the defect. So when you have a defect, try to go down, make your tibial cut 1 to 2 mm little more, but don't try to chase after the defect. Further on, if you're still not able to get it, you can lateralize your prosthesis a little bit and try to avoid the defect completely, like in this picture. But if the defect is more than 10 mm deep, a lot of studies have showed, and CT scan studies have showed, that anything more than 1 centimeter below the joint line, the quality of the bone, cancerous bone, becomes very weak. So do not try to chase after the defect. Next, you have something known as cement filling. Either you can just fill the defect alone with cement or in conjunction with a screw. This basically acts like a scaffolding. It's not really going to give you any more effect than a scaffolding effect. After that, if the screw is also not enough, you may have to go for a bone graft. Usually an autologous bone graft can be used. You take your proximal tibial cut first, take your cut bone and place it over there after making a shave, and then hold it with screws or K-wire, avoiding the keel, and then take off the remaining bone. The rationale is basically to form new vital bone through the process of osteoinduction and conduction. How about management in revision scenarios? The aim should be the joint line should be reconstructed as close as possible. Bone defects must be treated appropriately. Appropriate limb alignment must be attained. And revision components should have a comprehensive variety of metal augments as well. Should have that in your armamentarium. Surgical options, the use of cement alone or with screws. Bone grafting again, either structural or morselized. Modular augments like wedges or blocks. Metaphyseal sleeves and cones are the go-to implants nowadays. And of course, in severe cases, use of hinges and even custom-made tumor implants. Again, if you want to just see the management as per your classification, cement, if your defects are less than 5 mm, cement, 5 to 10 mm metal augments, and more than 10 mm, either a bulk or a allograft. So cement, it performs poorly in the long term. In isolation, it should be reserved only for AORI type 1 and 2 defects, less than 5 millimeters. Remains a good option in the short term, may be suitable for elderly patients. Cement with screws for any bone defects more than 5 millimeters. What about bone grafts? It allows the augmentation of the residual bone stock, and you have to contour the graft at the operation. The disadvantages are unpredictable union, which is quite rare, I think. So these are again of different types. Structural bone grafts are big ones. It has been achieved with smaller bone defects, and larger bone defects has shown variable early results. Morselized bone grafts have also been used. These studies have showed very good results, like this Whiteside's paper. And allogenic bone grafts can also be used. I'm not going to go into too much of detail there. This is a morselized graft, and this is a structural, a massive graft as well. How do you do it? This is the X-ray. You take, this is the defect that you have to shave it off to get a nice proper step, put your graft in there, and this is what the X-rays look like after it's been screwed in. Of course, you have metal augments. Surgical advantages of that is it doesn't have to be incorporated into the host bone, doesn't carry the risk of non-union or collapse, and can be applied very quickly. And unfortunately, we only have up to 20 mm deep. These are what the augments look like. They can either be sloped or they can even be a proper wedge shape like this. Okay, so again, you have to make a cut and then make sure that the augments are fitting. It can either be a tibial augment or a femoral augment. Okay, so this is what a tibial augment looks like. Of course, now we have the tantalum cones. These have to be used along with offset stems. It increases the contact area between the implant, the cone, and the host bone, and giving a mechanical platform, and less stress shielding is seen. The modular nature of the cones allows to fit in all types of defects, and the Nuric material helps rapid bony ingrowth as well. This is what the X-ray looks like with the cone. The sleeves now, we're using a lot of sleeves now at Sunshine. These are metaphyseal implants designed for the proximal tibia or distal femur. They're used in uncontained lesions, and they provide a structural fill to large central defects. So these are what the sleeves look like on the X-ray. Hinges, in severe cases, constrained prosthesis with a link is used, basically hinges, where you have global ligamentous deficiencies, post-tumor resections, and massive bone losses. Of course, the disadvantages are aseptic loosening, but by this stage, we may not have any other options. Okay, and custom-made prosthesis, like if you take this example, there was a supracondylar fracture, and they've put a plate, but that also failed. There's a huge bone loss there because you have to remove the whole thing, and that can be replaced by a tumor prosthesis. Just to you can just take a picture of the slide. We've already mentioned these. And to summarize, type 1 defects, you can use a cement, morselized bone graft, or even metal augments. Type 2 defects, you can use a cement with a step cut, then use metal augments, or you may have to use a structural bulk allograft or metaphyseal cones. Type 3 defects, metal augments directly, you have no option of cement, structural bulk allografts or metaphyseal cones, and then finally you have to use a hinge prosthesis or a tumor prosthesis. Thank you. Question? We'll head over to the next one.
Thank Dr. Adarsh. Now, Dr. Frederick will be online to present his case.